Good afternoon and welcome to July's Ask an Expert Anything panel discussion put on to you by Inspire Respiratory Critical Care and our team. I always want to start off by quickly introducing ourselves. My name is Keith. I'm a respiratory therapist in Virginia. Tom?
I'm a respiratory therapist in Ontario, Canada.
Madison?
I am a respiratory therapist at University of Virginia in Charlottesville.
Eric?
I'm a respiratory therapist at MedStar Washington Hospital Center in Washington, D.C.
John?
John Crock, flight respiratory therapist, Orlando, Florida.
Troy? Troy?
He's just muted. He's Troy from Missouri.
Troy from Missouri.
I'm here now. Sorry. That's right.
Snake
Troy from
charmer.
Missouri.
Andy?
Good afternoon, everyone. My name is Andy Klein. I'm a respiratory therapist from Chicago, Illinois.
And welcome to everybody out there taking part in this. A couple of things just to mention so that I don't forget to mention them at the end. This is recorded, and so this will be available on our YouTube channel pretty soon after we complete it today. Typically, we discuss our topic for about an hour or so. And so that'll be available after our recording here. And then please feel free to share that with anybody that you'd like to share it with. Our website is www.inspire-rt.com. Please, we'll put that in the chat at some point in time so that you'll have that you can go and visit our website for links for all of our discussions and all of our other media things that we provide. So today's topic is going to be regarding inhaled pulmonary vasodilators, and this topic is a little different than the ones that we typically do in that it's a little more physiology centric, but we're still not going to get too deep into the microphysiology, but we'll discuss that some. But we will keep it critical care centric. So there are certainly pulmonary vasodilators that are used chronically, both orally and inhaled. And we probably won't get deep into that, but we'll talk about the use of these pulmonary vasodilators in terms of their use in critical care. Our outline today we've already talked about welcomes. We'll talk about objectives, clinical rationale and mechanisms, agents, and evidence-based use, practical implementation and case reviews, challenges, controversies, and future directions. And my all-time favorite of any presentation that I'm involved in is audience participation. So please, if you have any questions or comments, go ahead and use the comment section and leave those at any point in time, and we'll get to them as soon as we're at a good spot. So anybody want to just start talking about the pathophysiology of pulmonary hypertension and RV failure? I can sort of...
Nobody wants to go down that rabbit hole. Come on, Keith, you could do it.
I could just go ahead and give a very simplistic overview of this.
I mean, Keith, you have a whole lot to say. You've been muted for the last 3 months. So
Yeah, this is payback. We're just all going to sit back and let you talk
for the next hour.
This is my time to shine, man.
Yeah.
All right. So pulmonary hypertension on its very basic primary level is hypertension or high pressure in the pulmonary vasculature. And I'm going to show you, or we're going to show you a couple of images that we use to sort of demonstrate what this means. But before we look at the images, basically, if you have pulmonary hypertension, that means that you have a high pressure in the pulmonary artery system, and that high pressure can cause a lot of different physiologic issues. And the one big one in adult critical care, which is what we talk about here, is right ventricular failure. And so if you have a really high pressure system in a pulmonary vasculature, then that means that the RV has to squeeze a lot harder to try to get blood flow and cardiac output through the pulmonary vasculature back to the left side of the heart, where it can then be distributed systemically. So pulmonary hypertension can be chronic, and lots of people have chronic pulmonary hypertension. They may take oral meds for that. They may take home inhaled pulmonary vasodilators. But when they get tipped over or they have acute pulmonary hypertension, then those are the patients that we typically see in the ICU. And those people may be hypotensive, systemically hypotensive, because they're having trouble getting cardiac output back to the left side where it can be distributed. They may have acute right ventricular failure because of this high pressure system. And if they have acute RV failure, then that can also contribute to shock and hypotension, cardiogenic shock. And so sort of those are the patients that we might see in the ICU. And we're going to present a case report here shortly. But some of the things that sort of or one of the major things that can cause acute pulmonary hypertension in the ICU is hypoxemia, right? If you think about the intrinsic pathway of hypoxemia causes pulmonary constriction when pulmonary vasculature articulates with alveoli that are dysfunctional. And so when you have enough of that pulmonary artery constriction or vasculature constriction, then you can have an increase in pulmonary vascular resistance, and then you have less preload for the left side, and you can have right ventricular failure. And so those are all things that can be deleterious for the patient. So, well, we're going to briefly show you some of the evidence here shortly. But this diagram here, if you can see it, really talks about the three inherent pathways for pulmonary vasodilatory action. And so if you look at the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway, and those are three separate pathways that sort of, and again, we're not going to get in the weeds here on this, but those are three separate pathways that sort of have the same end result when those medicines are administered. The endothelin pathway is the one that's least likely to be used in the ICU because those medicines are typically taken orally. And so if you have a really sick ICU patient, it's less likely that you're going to administer any of these medicines orally. Nitric oxide, and again, these are all naturally occurring in the system, but nitric oxide is one that's primarily inhaled. It is inhaled. It's a gas, and we know that. And then prostacyclin pathway is the most likely medicine that you're going to, besides nitric oxide, that you're going to administer to somebody via the inhalation route. And so those are the three major approaches. Again, this is just really a graphic of how those medications eventually get to a cellular level and cause pulmonary vasodilatation. So the most common agents kind of already sort of spoke about a little bit: inhaled nitric oxide, EPO medicines like Flolan and Velitre, probably the most common inhaled besides nitric oxide, iloprost, and all of these sort of are analogs to prostacyclins, and some of them are synthetic and some of them are naturally occurring.
We should point out too that these are all off-label in adult patients. I know the last bullet there says off-label agents, but inhaled nitric oxide is considered off-label in adult patients. Epoprostenol is considered off-label in adult patients as an inhaled treatment, simply because there's, and again, we'll get into the evidence, but just simply because there's no evidence of outcome benefit. But we just want to be clear that we're not stating the other ones are now on label and somebody missed the memo.
Right. Good point. Anybody else have anything to say up to this point?
I was just going to add to Keith, and this is something I was kind of surprised that isn't, I guess, more understood when we talk about pulmonary hypertension. But and I know that's not the focus of our conversation, but just be aware that there are multiple different classes or causes of pulmonary hypertension, and we don't necessarily use inhaled pulmonary vasodilators to treat all of those. Some of them were just trying to treat the underlying cause, like if there were a PE, for example, we wouldn't necessarily give pulmonary vasodilators to treat that. We try to remove the PE and so on and so forth. So, so while we do use these a lot for pulmonary hypertension, it's not necessarily indicated for every type or cause of the pulmonary hypertension that we might see.
And generally you have responders and non-responders, even when it is perhaps clinically indicated. You're going to have a percentage of patients that simply just don't respond to it.
All good points. And so I think that a lot of this is anecdote, right? Because like Thomas said, there's not good literature that supports the use of any of these medicines in the ICU. Better literature support some of these medicines for chronic pulmonary hypertension and keeping somebody stable at home, but not in the ICU for different etiologies of pulmonary hypertension. So really good points. So because a lot of this is anecdote, we tell stories, right? And so the case report that we're going to present here in a few minutes is really a story, right? You're not going to find robust prospective trials that say, hey, when this happens, you should do this. So although it's a very low form of evidence, that's what we have to present when that's what we have. So the first thing we'll talk about very briefly is the literature that supports the use of these medicines, which is not there. And this is a Cochrane review. If you're not familiar with these, very well-organized review of whatever kind of data is available for a particular topic. And this particular topic was to look at the efficacy and utility of inhaled pulmonary vasodilators. And so, as you can see there, the end result here of this review was that they say that there's no evidence to support the use of inhaled nitric oxide or any category of critically ill patients with acute hypoxemic respiratory failure. Inhaled nitric oxide results in a very transient improvement of oxygenation, but does not reduce mortality. It may be harmful as it seems to increase renal impairment. Now, if you do your own literature review, and I have multiple times, anytime I'm going to talk about this topic, I do a quick, hey, is there anything that's come out since the last time I talked about this? There absolutely is no good data to support the use of any of these medicines in acute hypoxemic respiratory failure, period, right? Now, this is very awkward sometimes to discuss this topic because there's so much effort in the technology to provide nitric oxide to sick patients.
Keith, I think that includes no evidence even during COVID-19. Is that correct?
Correct. Yep. You're right. Yep, absolutely. If we dissected some of the data, we could certainly. And if you follow our pearls, by the way, it's no coincidence that the pearls this week are talking about inhaled pulmonary vasodilators. So if you look at you guys that are watching and listening, if you'll go to there you go, boom, it's magic. That's science. Science is like magic, but real, right? So here we go. Anyway, no evidence to support it. Lots of effort out there to, and these are all studies for inhaled nitric oxide, and the other slide is for inhaled EPO. And so, again, every one of these studies either shows no change in outcomes with various endpoints, either no change in outcomes or worse outcomes. And so that's not an approach that you want to take if that's the data that you have to support what you're trying to do.
Yeah, and I think we should probably just throw out the or acknowledge the old elephant in the room. But the only reason why most hospitals were using things like Flolan or Veletri or whatever the other name, all the other names are, all the inhaled prostacyclins, is simply because the nitric oxide was extremely cost prohibitive for many institutions to have. This was back before the patent was over. Now that the patent's over, I think it's more competitive. I think you can utilize nitric oxide much more inexpensively than previously. And I know the healthcare system is completely different in the US than in Canada, but in Canada, many RT departments had to pay the budget for nitric oxide. So as an educator, I was constantly trying to remind people of the evidence so that we weren't using it just freely and then ramping up our bill for the product. And then we eventually got forced when we decided to do budget savings in one of the hospitals I worked at, and we had completely eliminated the use of inhaled nitric oxide in that hospital. We were forced to have a solution or a substitute, which is where Flolan at the time came into play.
Right, and so we're not talking about babies, right? There are times where, and I certainly would never intentionally talk about babies to begin with, but we can certainly mention that the evidence and support for the use of inhaled pulmonary vasodilators in babies is different. But that's not what we're talking about.
Yeah. And in terms of like on-label use, it's not, I still think it's not on label for preterm infants, but specific conditions at term it is considered on label. So there's no issue with you using an off-label therapy. Anyone else can correct me if I'm wrong, but I think it was still off-label for premature. It was used. There's many studies, but it's still considered off-label because the evidence is inconsistent.
I think it's 34 weeks.
Yeah, 36 maybe for persistent
Something
pulmonary
like that.
hypertension in that ballpark.
That sounds right.
Slightly
So-
premature,
Yeah.
but not the preemies that we often discuss.
Not to see through babies. Yes.
So Keith, is this where we talk about where and how we should use it? I mean, if we're saying there's really no great evidence and there's no evidence-based approach to its utilization, but I think it's still pretty prevalent in its use, right? Do we talk about it now, or you want to talk about
Eric,
it later?
Let's talk about it now. But first, I just want to make one quick point,
Yeah.
which I think is going to kind of wrap up what we've talked about so far, and why we think there's no evidence to support its empiric use in hypoxemic respiratory failure, and that is the same thing that we always talk about, and that is that an improvement in oxygenation is not a corollary to improvement in outcomes. Right. There's so many things that we do that can improve oxygenation. Again, and we say this almost every time we have a panel discussion. If you look back 25 years ago at the ARMA trial, the control group which was the large tidal volume group, had higher mean PO2s than the study group, which had much better outcomes, right? And so just because we can do something, just because we can place somebody on an inhaled pulmonary vasodilator, and just because we can make their PO2 go up some, does not correlate does not mean that their outcome is going to be better. So that's why when we study this, or when we've studied this, it supports that whole that perspective, right? And I know that everybody here agrees with that. But yeah, so Eric, go ahead and start telling us when we should use it.
Yeah, I don't know. So I think what might make the most sense if we're talking about its use in hypoxemic respiratory failure and not necessarily within, pulmonary hypertension or right ventricular dysfunction, just strict hypoxemic. I don't know whether you have a solid argument or not, and I think it really depends on your workflow and the acuity and exactly what's happening in any one particular case. But I think most people kind of argue it's for its use, not necessarily myself in some cases, but as a bridge to getting to the evidence-based guideline, right? And so. I don't know. Sometimes I feel a little deflated because then I got to argue against it. Like, how hard is it for us to prone in the bed? Do we really have to wait for the proning bed, or can't we just prone right now? Immediately and that sort of thing. And so that's kind of, I think, the anecdotal what I hear, right? Like, we understand the data, Eric, as I start to argue, and we're using it as a bridge to get to the evidence. And so we've already done this. We're getting ready to prone. And we're just trying to get there. I don't know whether, how strong that argument is or is not, but I think that's kind of what I see in general. I think it gets really frustrating, as you try to then peel it off with evidence-based practice in there, right? And say, because a lot of the times people feel it's benignness, right? Like they're like, this is easy this is easy. It's just sitting there, and I want to kind of undo these other things prior to me undoing the vasodilator, right? And so then it gets into, all right, now we've been on this for X number of days. You push this into it as a bridge, and we're at the other end of the bridge. Can we undo this type of thing?
Yeah, I think you brought up a number of really good points, Eric. And the one I do want to highlight is that we're not shaming anybody for using inhaled pulmonary vasodilators. We've all used it. The bottom line is that it's exactly as you pointed out. It should be viewed specifically in patients with hypoxemic respiratory failure, that if you are to utilize it, it is a bridge to, like, what is your plan? What is your next step? Because this step does not save your patient. It's going to make your PO2 look nicer and you're going to feel better, but it doesn't actually change outcomes. So you have to ask, is there anything that does change outcomes? And you brought up prone positioning. And this was one of the strangest things I thought when COVID hit and people were starting to prone more. Hospitals and again, this is not a Canadian thing. In Canada, we don't have these proning beds. But when people were like, oh, we don't have access to the proning bed, I'm just like, the ProSeva study, which was the most impressive proning study we have to date, they literally used like 3 people at the bedside to prone people. Now I know the size of the patient matters, but you could prone a large patient with 5 people. You don't need to wait for a bed. So if you're starting nitric because you can't prone because you're waiting for a special bed, the issue is that proning will likely improve your oxygenation, and we know that it improves outcomes. So when you are using it as a bridge to something, if it's faster to get to that bridge by changing your policies and your protocols, then you should be doing that. The second thing is, in terms of policies and protocols, one of the issues that I've run into clinically over the years is that if your protocol does not have a specific comment about what is a response to nitric oxide, and if that response is not there, that you have the ability to turn it off. Because what happens is you start it, and we're like, well, let's give it more time. No, this is a fast onset type of drug. We're not waiting 4 hours for it. It's not like proning where it might take a while to like really show some improvement sometimes, but nitric oxide, it's not, or inhaled Flolan, it shouldn't be something that you're waiting hours to see if it's working. And this was the biggest problem we had when it was cost prohibitive is that people would put it on, there'd be a minimal to negligible response, and then they would leave it on. And then, of course, and we might get into this, but when you take it off, specifically like nitric oxide and Flolan as well, there's this potential for this rebound effect where they're going to appear worse when you turn it off. And then what's the knee-jerk reaction? You turn it back on again. So then you have this prolonged therapy that's actually not changing outcomes. It's not cost effective when you think about the actual benefit you're getting. And at this point, they're probably not getting the benefit of an oxygenation benefit that has been prolonged. Most of the studies that showed an oxygenation benefit within 48 hours, that benefit was no different than placebo. So, we have to consider this, that we make these decisions rather quickly. And sometimes our hands are tied by physicians, but getting, a physician lead on board with like, listen, we don't have the evidence, so let's at least have guidelines for when we can stop providing this therapy rather than just leaving the patients on it.
I think it's funny. We've run into a little bit, because a little bit of the opposite problem when we were using nitric, which was 2008, so 17 years ago. We were really good at turning it off when they were non-responders because everyone knew it was just so wicked expensive. Now that we've replaced it with what is in people's minds a really cheap alternative, it's much more difficult for us to pull it back because they're like, we don't have to worry about how much it costs anymore. Like, just give it to them, and you're just like, So, kind of that funny interplay of the economics of that.
The cost difference was definitely significant, but it wasn't. Yeah. It wasn't completely negligible. And I remember when we switched to Flolan, I tossed out the idea of like, why don't we put this on pharmacy's budget, and then we'll see how quickly it gets weaned off when it's not not effective. Because when the RT department's covering this sort of upfront cost for this thing, people just keep pushing it because it's so much cheaper than our other solution. Whereas if you put that cost onto somebody else, you'd be surprised how quickly that gets turned off.
Yeah, I think our volume of patients is also much higher now too. Like just the sheer absolute numbers of patients that were willing to do this. I felt like we were just so much more cautious with its use because of its cost prohibitiveness. People were tiptoeing up to it, because everyone would, ask questions about such an expensive use of such an expensive agent, and then we switch and nobody has those questions anymore. It's created a different set of problems. But so I think having a well-established bridge to an evidence base is, you gotta have that. And then you can argue about and you have the fight.
Yeah, and I think we basically just covered this slide with this conversation now that I'm looking at it. Specifically the monitoring parameters, you could suggest, like, what are we monitoring to ensure that this is what we would consider a positive response to it? And then the weaning considerations, dosing strategies. I believe most protocols are sort of start high and then go down. But I honestly feel like this sometimes gets overlooked as well. They start high, and then if the patient responds, nobody wants to touch it. The whole purpose of this was to find the minimum dose required to achieve the physiological response. And so rather than starting low and slowly going up, you get that response. But then the whole idea was to wean and back it off until you maintain that response on the minimum possible dose. But again, I've seen numerous times issues with just us being allowed to wean per protocol. And they're like, why did you turn it down? It's just like, because they responded and now we're trying to find the minimum dose. No, turn it back up. It's like, okay, sure.
I think it's important that we mention that the literature really supports 20 parts per million, I think, as a starting point.
For
that
oxygenation,
using 40 parts per million, that there was no difference in outcomes. Is that correct?
I think that delineation, if I recall, was for an oxygenation indice versus a pulmonary hypertension or right ventricular dysfunction, right? That was the really high one. I wonder, we had always kind of had this conversation, and it's been a while since I kind of went back and really, really looked at it. But, I think with the higher doses, you lose the you lose that effect of the redistribution of blood flow because of the, clearly you're only trying to send it to well-ventilated alveoli, but if you have localized areas of underventilated or shunted alveoli that are really nearby, you end up in really high doses in this creating an increase in shunt, right? Because I don't know how where that lies now, but I think that's where you may have seen like, oh, you need to keep the dosing low as opposed to going really, really, really high.
I just posted a question. I just posted a question in the comment section. If anyone can see it, any of the attendees, if you want to sort of chime in and say what your starting dose is for inhaled nitric oxide in the hospital. Because again, like this was the whole idea, is that if the average dose for this response is around 20, I think a lot of places were just like, let's start high and wean down immediately. But the problem is again, that I'm talking about essentially like 2 hospitals that I worked at where the issue, where this issue was prevalent, where we would start it at 40. And then when we try to wean it, they're like, no, leave it. And it's like, you could have a positive response with 10 parts per million, but most people were so some are saying they start at 40. Okay. Or 50, sorry.
I wonder if that 50 is nanograms per kg per minute of Velitri or Flolan.
Well, I asked the question specifically inhaled nitric oxide. So if that 50, that could have been a response for that as well. Yeah.
Who all here is I guess
that's for Velitri. Okay, I was referring more to nitric oxide, so it'll be parts per million, but. That's starting at 50. That's usually 15. Is it nanograms per kilogram per minute? Is that the?
That's nanograms per kg per minute. Yeah. What else are you guys using nitric? Andy, it looks like you are.
Yeah. One other thing I wanted to point out before we move topics, and Eric, I think this is an offshoot of what you had said. We're the same. We use it as a bridge to other therapies. And then also, like I'm sure most people here, we're at the end of the rope. ECMO said no, can't be proned, or we're no longer responding to proning, or we have a contraindication of proning and there's nothing else to do. But we haven't added nitric, or we haven't turned up the nitric. We'll use it in that way too. Everyone just feels better if they die with nitric running versus if they die without nitric running, right?
We did all we could do.
Yep, we did it. We threw everything at them. But the other thing I wanted to say is, and what I've run into here, and I want to make sure people are clear on this, adding it as a bridge, make sure you still cross the bridge, because what happened a lot of times with us, now our PF ratio is 185, and do we really still need to prone now that the nitric has fixed the problem? And really having that targeted discussion of, no, the nitric made the numbers look better. The problem still persists that we need to prone them and get them on a more lung protective strategy as the evidence supports for outcomes, not, okay, now our PF ratio is beyond the criteria for proning. Let's not prone anymore. So it can mask the problem a little bit by falsely elevating that PF ratio or that PO2 in general. So, if you started and if it improves things, great, but still do the evidence-based therapy that has a chance to improve your outcomes as well.
Now, I'm going to bring up a comment, one more time, because I want to get John's comments and perspective, because in my mind, probably one of the most useful, I would think one of the more useful situations to have inhaled nitric oxide as a bridge is in, of course, transport. I feel like this would be a no-brainer, because proning a patient while transporting, you've probably done it, John. I wouldn't be surprised. Maybe you haven't, but I wouldn't be surprised if you told me you had. But we know that would add so much complexity with transferring a patient. So clearly, this would be a perfect solution, in my mind, a use case for nitric oxide to bridge that gap between perhaps peripheral center to like a more academic center where they are comfortable proning, et cetera. So John, let's get your feedback on that.
So my tankless nitric fans are going to really appreciate what you just said, because those are the ones that tend to want to get into the transport realm to help us out with that. Quite honestly, we don't transport nitric on my aircraft, and we don't prone obviously in the air, but we do use Flolan. And if we have a patient who's on nitric at a sending facility, we would like them to transition to Flolan because it's ease of use, because of its cost effectiveness, because it's easier for me as the RT to have access to the syringe pump and so on and so forth. So,
yeah, and I apologize for generalizing nitric oxide. I meant inhaled pulmonary vasodilators.
Sure. Yeah, and we do use inhaled pulmonary vasodilators on those patients that are on nitric, and even some patients that we transport that we feel would benefit from it. So, and again, you guys had talked about trying to think of what we were just discussing, but it goes back to why are we putting these patients on nitric in the first place? We talk about ARDS. We talked about the Prosiva trial, and that has actually a better benefit than the ARDSNet did, but we still throw all our eggs in the ARDSNet basket. So we don't prone in the aircraft. I don't know really anybody. The folks that I've spoken with when I was doing a lecture on proning in the air, talking to some of the other big programs around the country, they don't prone either. There is actually up your way. There is folks out of Halifax that do. They have a larger aircraft than we do, and they actually have a protocol for starting proning patients in the aircraft. But again, different animals.
I'm still going to give you credit, John, that if anybody had prone somebody in the air, I just would assume that you would have done it at some point. But
when I did this, when I did the lecture, there was like 5 instances over a 5-year period of them studying patients and proning in the aircraft, and it just wasn't worth the
I can't imagine the complexity of doing in such a small space. But
again, even going back to some of the folks out there now that are pushing the tankless nitric, I mean, it's still not attractive for us from an aircraft perspective, because again, there are logistics involved. There's weight limitations. There's some other things that we looked at when we were looking at tankless systems. But nonetheless, we don't use nitric in the air. We use inhaled Flolan, and that's just for our ease of use. And again, when we don't have a whole lot of patients that are being asked to go on nitric. We have, I think, in the past 4 or 5 years, even pre-COVID, we may get 3 or 4 requests per year, and then it's mostly cardiothoracic surgery that wants it. And then we say, look, we don't transport inhaled nitric. Can we switch over to Flolan? Absolutely. In some instances, the surgeons are like, just turn it off. Just turn the nitric off. And those patients do okay as well. So
I'd like to, all good points, Andy. I would consider that a complication. What you're describing as a complication of the use of nitric, right? There are several complications that are legitimate. We think, right, and correct me if I'm wrong, or if you have a different perspective on this, but the improvement in outcomes with proning are not due to an improvement in gas exchange, but rather a change in the distribution of transpulmonary pressure that sort of mitigates VILI, right, ventilator-induced lung injury. And so I think most people that believe in proning, it's nice if your PO2 goes up. It's nice if it goes up and you can turn the FiO2 down. But I think sort of like with the use of neuromuscular blockade, it's not that even though your PO2 improves, most of the time when you do that, it's probably a decrease in injurious ventilation that occurs when you prone somebody and when you use neuromuscular blockers. Some of the other things, some of the other complications or side effects, if you will, all these medications affect platelet aggregation, right? So if a patient is bleeding, for instance, maybe nitric oxide isn't the way to go with a trauma patient that's got a lot of significant bleeding problems. Production of methemoglobin is a problem. Now, I can tell you in my early years, I used a lot of nitric oxide, and I very rarely saw a methemoglobin problem, but it's been described in the literature, and it may go up, and if it goes up enough, then that's a problem. Acute hypotension, right? Go ahead.
I was just going to say, I wanted to make a joke when you said, back in my day, I used a lot of nitric oxide, and now I get flashbacks and I see trailers.
That's not untrue, actually. acute hypotension. Let's say you have a patient that's got biventricular failure, right? They've got RV failure. You start this nitric oxide or this Valicia or whatever, and all of a sudden you're flooding the LV with all this blood that it's not used to seeing, right? And all of a sudden you got this extra volume in the LV that it can't handle, and that Starling curve, and it can't deal with it. Then you get acute worsening shock. And I've seen this again. A lot of this stuff is anecdotal that we've seen at the bedside. You get this shock that the patient might not be able to recover from. And I've seen
not only that, Keith, but flash pulmonary edema, right? That
Yes,
fluid's got to
yes.
go somewhere. The left ventricle can't keep up; it goes back into the lungs, right?
Right. And so you have sort of had a paradoxical effect, if you will, in that what you were trying to do didn't happen. The opposite occurred. That rebound that Thomas was talking about is not unusual, and I think the reason for that is that if you think about what nitric oxide is, it's an imperative molecule that's in your body doing its job all the time, and so but it occurs in your system in parts per billion, right? In parts per billion. So compared to a part per million, it's a very small quantity. And when you start giving somebody exogenous nitric oxide in the quantity of parts per million, then your body sort of downregulates its endogenous production of nitric oxide. And I think everybody's different. Patients are all different in terms of when you stop giving them exogenous nitric oxide, how quickly they start their reuptake and production of endogenous nitric oxide. And I think that most papers or most of the literature that you read will talk about that delay. And I think that delay is what causes this rebound effect, right? So, and that's why you don't see the rebound effect until you get to very low doses of parts per million, very low parts per million. And I think it's primarily, the DNA structure that determines whether or not somebody's going to have a huge delay. Not everybody fits in the same basket. So there are certainly complications to using a medicine that has no support for improvement of outcomes that should be considered. And again, I love the term. Sometimes I forget to use the term bridge to something, but back when I was very involved in ECMO, ECMO's got to be a bridge to something. And I think that, like bridge to transplant or bridge to end of life decision making or bridge to whatever. And I love the ideology of thinking about nitric as a bridge to something, and a bridge to proning, like Andy said, or whatever that might be. And although I loathe the idea of using nitric oxide in adults, I just don't like to do it. Again, I wouldn't shame anybody for doing it. I've been there. I've been like, wow, what are we going to do now? We've done everything else that we could think of doing. This guy's PO2 is in the 40s. What are we going to do? That being said, sick ARDS patients don't die from hypoxemia. That's not what they die from. They die from multi-system organ failure that's precipitated by high energy applied to the lungs and other, hospital-acquired infections, things like that too. But man, very few people die from hypoxemia. I'm trying to catch up in me missing a couple, not being able to speak at a couple of these things. Anybody have anything to add on to what I said before I go through this image here?
No, Keith, I think that's kind of what I was going to bring up too, is that, we look at multi-organ dysfunction as the main, mortality effect of ARDS. It's not so much hypoxemia, and yet let's introduce an exogenous gas that could cause harm down the road. So again, I'm kind of like you. I kind of loathe the use of it in the adult population. But again, not shaming anybody because we use it down here a lot. Just in the aircraft, we don't. It's easier for us to switch over to flow-in.
Right. We're gonna. I don't know. Can people see that the images there with the alveoli and the pulmonary capillaries. Basically, the idea here is that the reason why it's popular to use an inhaled pulmonary vasodilator is that you want to get the dilator to the pulmonary capillaries that articulate or butt up against alveoli that function, right? It doesn't do you any good to get the pulmonary vasodilator to the vasculature that butts up against alveoli that are dysfunctional. So that's sort of the reason. If you're going to the idea is that you want to improve VQ matching, and the only way you're going to do that is if you get that if you dilate that pulmonary capillary that articulates with that alveoli that are functional. If you look at that very rudimentary heart there that's in this image, I can't use animation. This is an animated slide, and I can't use animation in this format right here. But if you think about the way that you probably all teach hemodynamics, and if you divide the heart up into its four quarters, the right atrial pressure is usually around 10, or around 5. The left atrial pressure is around 10. The right ventricular pressure is around 25, and the systemic pressure is around 100. Those numbers are used because they're really easy to sort of remember. Nickel, dime, quarter, dollar, right? So when those pressures are correct, then you have very little impedance to blood flow through the pulmonary vasculature and back to the left side of the heart where the oxygenated blood can be distributed systemically, right? But if you look at that arrow that's going towards the lungs there, if you can think about that as your pulmonary artery system, that's your pulmonary artery, which branches off obviously to the right and left side. And if you have an increase in pulmonary vascular resistance, let's say from hypoxemic pulmonary vasoconstriction, pulmonary embolus, which somebody mentioned earlier, if you have an increase in your pulmonary vascular resistance because of that, and that resistance acutely changes enough to cause your RV pressure to go up, which it will, and then your pressure in the RV goes up enough to cause your right atrial pressure to go up, then all of a sudden, for the first time since you were born, because when you're in utero, those pressures, the atrial pressures are switched, right? And so for the very first time since you were born, your right atrial pressure is higher than your left atrial pressure, again, which should be nickel dime, but now it's flipped. Then you can have blood flow from the RA to the LA that never takes place in the pulmonary vasculature, never goes through the lungs, never gets rid of CO2, never picks up oxygen. And so all of a sudden you've got a blood flow that's not getting oxygen, not bringing oxygen back to the system. So that can be bad depending upon how much blood flow you have going through that right to left shunt, right? And so the idea is that if you can, and I've done this several times at the bedside where we thought we had this problem, and then it didn't turn out that was the problem. But also have seen it where we did an echo. We did a bubble study, which is when you inject agitated saline and you watch through the echo and you can see bubbles floating between the RA and the LA. And then you start nitric and that goes away. So, the idea being that if you decrease the pulmonary vascular resistance with the inhaled pulmonary vasodilator, then you might be able to get those pressures back to normal or quasi-normal and get that shunt to improve, because your hypoxemia is going to be refractory from that, right? There's nothing, you can pump up as much FiO2 into that patient as you can get in there. And that problem, if that problem is a rearrangement of hemodynamics, then that hypoxemia won't improve, no matter what else that you do. Right. So that's basically what I wanted to show everybody there is that derangement of hemodynamics and what that can cause.
So in terms of some practical application of the ultrasound at the bedside, Keith, what would you recommend to the RTs that, are evaluating this patient and there's a high suspicion that there's some right heart failure? How necessary is it to wait for the bubble study versus point of care ultrasound?
Well, so I agree. I mean, we in the ICU, I think that all of us here would agree that we do this almost daily, right? Where we have a problem. Point of care ultrasound is so common now. It's very easy to put the ultrasound on the chest. And if you have this problem, then you should have a dilated right ventricle. It's unlikely that you have this significant of a problem and not have an enlarged RV. So that's definitely a first line evaluation at this point in time. Anybody else do this on a regular with chest POCUS?
We have done these bubble studies simply like when any patient seems refractory hypoxemic, one of the hospitals I worked at, it was very common for them to investigate this because I believe there was a study that included Laurent Bouchard years ago, and they found a significant percentage of patients had undocumented issues with PFO. So it was kind of, and we know that a large number of the population has an issue that they might never know through their entire life until they get critically ill, and these changes start to happen within their vasculature that then present itself as this problem. But it was one of the things we would investigate during when a patient was refractory hypoxemic, like beyond the expected amount based on their clinical presentation.
Yeah, and even minus the PFO, right? If you do an ultrasound at the bedside and you see a huge RV, then that's just one of the pieces. Okay, well, if the RV is dilated, then there's some sort of obstruction to the pulmonary vasculature. Is it pulmonary hypertension, or is it a huge pulmonary embolus? You use that piece of the puzzle. Are they in shock, or are they on rocket fuel for vasopressors, et cetera? And you can just sort of use that as, okay, well, let's try this first. Like Andy said, let's try this nitric oxide as a bridge to getting to the cath lab or IR to the thrombectomy, or we start systemic anticoagulation to treat the embolus, or whatever the experts in that area decide that is the best approach. But that's always a good first step.
We're running a little low on time here, Keith. I don't know if we want to.
Yeah,
we've sort of mentioned some of the delivery methods. We know that inhaled epoprostenol or all prostacyclins require like IV pumps. Most ventilators have been tested by companies that utilize inhaled nitric oxide. So it's one of the benefits. Although inhaled nitric oxide is off-label and it might be more cost prohibitive, those companies do a lot of R&D with ventilators to ensure that their delivery is functional through most modern day ventilators. Whereas when you're dealing with inhaled epoprostenol, you're hopefully using a good quality nebulizer, like a Aerogen, for example, like a vibrating mesh nebulizer. But those vibrating mesh nebulizers can't be at fault when something like Flolan or epoprostenol is not functioning properly, because these aren't drugs that are intended to be nebulized and inhaled, again, off-label. But that's one of the main differences, I would say, in terms of how things are delivered and the testing involved with that.
Yeah. There are certainly some interesting I won't say complications, but things that sort of impede your ability to get some of these things done with different interfaces and syringe pumps and all these things. But that's sort of things that you need to work through at your institution because it's difficult to know what what your specific problems would be. I think we sort of went through that case report without actually going through the case report.
Yeah, I made a chat in the private chat being like, should we posit the case report or just take this example that Keith's giving as a case report? So I think we'll just use your example of the PFO.
Sounds good. You certainly need to know how to use. You certainly need to know how to use your equipment, right? You can't. This is no time to start a therapy and then not. As an example, syringe pumps and Flowland. It's if your patient is a responder to that and they're depending on that Flowland, this is no time to mess up the transition from an empty syringe to a new syringe, and make sure that you have those things figured out first.
I think you also, I'll speak deliberately to the challenges of that because we deliver Velitri, we deliver a fair amount of Velitri, to the tune of, close to 70 patients a month type of deal, right? And so we're a big, pretty large cardiovascular center, and so we're doing a lot of it, not for oxygenation, but for RV dysfunction and so on and so forth. And so we use Velitri. We've had any number of challenges with Velitri. And we've worked through many of them with concentration changes so that we can just what you are talking about, because every time the syringe is going to empty, you can't let the syringe run out clearly, and there has to be adequate workflow allotment for that change to happen. And when we have a unit that is running 10 Velitri pumps at any one time, that's a lot of work for individual therapists. And so the amount of times that you have to change that syringe is about 6 times a day, every 4 hours. It's quite heavy. So we've looked at syringe concentrations, and we've increased those so that we can decrease the amount of times we change the syringe. I think one of the other peculiar challenges that you run up against with inhaled prostacyclin, like Velitri or Flowland, is its constitution in terms of it, just for lack of a better word, it's sticky, and you can't let it get into your ventilator, and so you have to have provision for filters on the expiratory valve of the ventilator, that then those filters, in protecting the ventilator from the medication going into it, those get gummed up, and so those have to be changed. And if not, you present a very real obstruction to airflow during expiration. And so we've had any number of challenges and things. And so those, going back one slide, those were some of the big challenges that we've encountered over the last 15, 16, 17 years in delivering Velitri as opposed to an inhaled nitric. And the nebulizer function itself is not alarmed. The pump can be running and the pump looks great. The nebulizer is stopped for whatever reason. So I think there's careful and due diligence that needs to be had with either of the systems, but I'm specifically talking about the Velitri and Flowland systems.
All right.
All excellent points. We are at the end as usual. And again, thank you everybody for to the panelists and of course the participants. We have to go, but this will be available on our YouTube channel soon. And look out for our next topic. Go to our website, recommend topics. We take those from people and sort of incorporate them. So anyway, thanks very much.
Thank you.
And everybody have a great afternoon.
Bye, guys.
Bye-bye.
Bye, everyone. Thank you.